Okay, let's go ahead and get started here. We're going to take another look at the muscles of the body today. And I have not set any kind of date yet for the lab exam for this. We have to get through the lab exam 2 first. Lab exam 2 opens up on Friday and stays open until the following Friday. I think it's the 25th. I think it opens on the 18th and closes on the 25th. So for the lab exam, and then we'll figure out when we're going to have lab exam 3 at some point. So we're well on track to get all the content in. Because after we get done with muscles, then we get into the good stuff. We can dissect brains and eyeballs, so, which is always popular. Okay. Anybody have any questions on anything? Okay, then I'm going to go into muscles again. Okay, here we go. Okay, the list of muscles is found in 2 places. We have a study guide that's found in the e-learn content section of this class. And you have a list of all the muscles there, plus their origins, their insertions, and their actions. And in e-learn also, where you find the PowerPoint for this, you'll find a list of the muscles too. So you have 2 places to go to look for that. There is no study guide for this lab test because it really is look at the muscle, identify it, look at the muscle, identify it. A few of them that I want to emphasize, you need to understand their origin or insertion or their action. And I'll be very clear when, as I go through this again, this time around, that which ones those are, because there's a lot of them I'm not going to bother with because, but there are some that are just pretty important to understand. Okay, so muscles are attached to bones in 2 places, at least 2 places. We've got the origin of any muscle is going to be where it's attached to a bone that doesn't move. So for example, the example we use here is the sternocleidomastoid. The origin of the sternocleidomastoid, the muscle that comes up from right here at the sternum up to the mastoid process, its origin is on the sternum and the clavicle. You can have more than one origin for a muscle. In fact, like the origin of the gastrocnemius is on the medial and lateral condyles of the femur. That's its origin. It has 2 origins. The origin of the rotator cuff muscles, all 4 of those come off of various locations on the scapula. So, but the origin is going to be the bone that doesn't move. And the insertion is where the muscle is attached to a bone that moves. So, so for example, if you're looking at the Biceps Brachii, its insertion is on the radial tuberosity. The radius moves when you flex the arm. So the origin is the point of attachment to a bone that doesn't move. Insertion is the bone that moves. You're always going to have at least 2 points of connection. You can have more. The triceps has 3 origins. The sternocleidomastoid has 2 origins. So you have, but you're always going to have at least 2 points of attachment, 1 origin and 1 insertion. That's the minimum you can have for it. And you're always moving a bone. Movement is always due to moving a bone, at least when you're looking at muscles and the skeletal system. And again, the bone that doesn't move is the origin. The bone that moves is the insertion. And here's our classic example. This is the sternocleidomastoid. You can see it has two heads that originate on the sternum and on the clavicle. That's where the term sternocleidomastoid, we get the origin in the first two parts of its name. Mastoid is the insertion. It inserts on the mastoid process up here behind the ear. So there's its insertion right there. And its origin when it comes around again is right there. So let's take a look at the arm now. We'll start with the arm and work our way down. Okay, first muscle we see in the arm is one that nobody ever gets wrong. It's the deltoid muscle. The deltoid is where we tend to get most of our injections. It covers the shoulder. It is this thick, fleshy muscle right up here. And I guess I had to label it. There's the deltoid. And the deltoid muscle attaches itself to the humerus at the deltoid tuberosity, a structure that you should know from the humerus, the deltoid tuberosity, that bulge about halfway down the shaft of the humerus. So that's the deltoid muscle. Below that, on the anterior surface, is the biceps brachii. Now, we call it the biceps. We call it the biceps because it has two heads. And we call it the triceps, the tri, because it has three heads. It's a really clever naming strategy there. There's the triceps on the posterior surface. The triceps and the biceps are antagonistic. They work against each other. Many of our muscles are paired like this, where one is the antagonist to the other. We see it with the hamstrings and the quads, for example. We see it with the Tibialis Anterior and the Gastrocnemius, because we see it with the biceps and the triceps. They work against each other. We see it with the external and internal intercostals. They work against each other's actions. Now, in between the biceps and the triceps, oh wait, I'll sort this in here. That's the teres major. There's the one. There's the brachioradialis. There's the one I was trying to say. The brachialis is in between the biceps and the triceps. Now, a couple of these muscles here are pretty important to us. Teres major, not so much. Just be able to identify the teres major. Same with the brachialis. But the brachioradialis is pretty important to us. The brachioradialis originates, and don't worry about where it originates or where it inserts, but it originates on the end of the humerus and inserts on the end of the radius. What it does is allows us to turn our hand like this, like opening a doorknob. So if you're turning a doorknob, turning a key, turning a screwdriver, any of those kind of actions, you're going to be using your brachioradialis, because the brachioradialis wraps itself around the lower arm. Now, and allows us to move. The term is, I'm not going to belabor here, pronation and supination, where you can turn your hand upright or turn your hand down. And a lot of that action involves like opening a doorknob, turning a key, and things like that. So that's the brachioradialis. Okay. Now the deltoid, you know, it inserts on the deltoid tuberosity. It covers our shoulder. It does various different actions here, but just remember what it looks like and where it is and where it inserts. Okay. Now there's our brachioradialis. You can see its origin is near the end of the humerus, and it inserts at the distal end of the radius, almost on the styloid process of the radius. And again, the whole rotation of the arm, because you know how the radius will rotate over top of the ulna when you're turning something. It's the brachioradialis is one of the muscles very much involved with that kind of action. Okay, now let's take a look at this first set of antagonistic pairs, the biceps and the triceps. They are antagonistic muscles, meaning they work against each other. There's the biceps, there's the triceps. Now the biceps is going to allow us to flex our arm, meaning if you have your arm straight out and you bring the fingertips back, you bend at the elbow and bring the fingertips back where they touch the shoulder, that's flexing. And since we can't go around like that all day long, we have to get our arm back, so we extend the arm, and that's extension. The biceps is involved with flexing, the triceps is involved with extension. So there's the biceps brachii. Its origin is on the scapula, but more importantly, its insertion is on the radial tuberosity. The insertion of the biceps brachii is the radial tuberosity, and it allows you to flex the arm at the elbow. That's its action, flexing the arm at the elbow. And you can see on the animation there, you can see the biceps brachii on the anterior surface of the arm. It's inserting itself on the radial tuberosity, that little bulge on the radius just below the neck of the radius, and it pulls the arm up. Since we can't go around like that all day long, we have to be able to extend that joint. And that's what the triceps does for us. The triceps inserts itself on the olecranon process, our elbow. And if our arm is flexed and we contract the triceps, it will pull our arm straight out. So if you had your fingers resting on top of your shoulder and you wanted to straighten your arm out, your triceps would pull on the olecranon process and you would extend your arm. And so they work totally against each other. Notice on the animation that the triceps, all three, with three heads of it, inserts itself on the olecranon process on our elbow. And when the arm is flexed, it will pull it back into its extended position, extending the elbow joint. So now here's what we hear. I mentioned this 2 weeks ago, and I'm sure everybody couldn't wait to hear more about the rotator cuff. But the rotator cuff, we hear a lot about that. It's a common injury at two age ranges in our population. Adolescents and young adults tend to injure their rotator cuff in contact sports, and then older people, elderly people, older people tend to injure their rotator cuff during exercise or just because, or in accidents because it's worn, it has worn down. The rotator cuff is a group of muscles. There are 4 muscles that all originate off of the scapula. So the rotator cuff muscles are easy to remember. They all come off the scapula. They all insert on the head of the humerus, and they form a ring around the head of the humerus, which we call the cuff. And that gives us this incredible range of flexibility with our arm. We can rotate our arm almost in a full 360 degrees as these muscles pull on the head of the humerus in different directions. And plus, since the glenoid cavity is not much of a socket, it is, it's not a socket like the acetabulum is at the hip. It's like a dish, like a flat pan. The 4 rotator cuff muscles hold the head of the humerus very tightly against that glenoid fossa, if you will, so we can have this range of motion. Now the muscles are, the names are familiar to you, at least 3 of them are. The supraspinatus, the subscapularis, and the infraspinatus, and then we have the teres minor. That's the 4th one. The rotator cuff muscles, the supraspinatus, it rests in the supraspinous fossa, the fossa above the spine. So, supraspinatus, named for the supraspinous fossa. Then we have the infraspinatus in the infraspinous fossa. And we have the teres minor, also in the infraspinous fossa area. So these are on the posterior surface, remember, because we're looking at it from the backside, from the posterior surface of the shoulder. We've got the supraspinatus, the infraspinatus, and the teres minor. On the anterior surface, the side that's butted up against the ribs, we have the subscapularis in the subscapular fossa. So if you know your structures on the scapula, you know where these muscles are located. So these are the 4 rotator cuff muscles. And again, there's the supraspinatus, there's the infraspinatus, there is the teres minor. Now, the other muscle here, the one down here, I didn't save it there. This is the teres major. It is not part of the rotator cuff. But I point out that the teres major, I showed it to you on the earlier slide. If you have a major, you're going to have a minor. If you're going to have a minor, you're going to have a major. If you have a superior, you're going to have an inferior. If you have an anterior, you're going to have a posterior. Those rules are pretty good in keeping track of everything. So if you have a teres minor, there's a major, but the teres major has nothing to do with the rotator cuff muscles. Okay. So, and again, what do? Well, they hold the humerus attached tightly to the glenoid cavity. You can see here just how, you can see the tendons holding the humerus in place here. Now, this is the type of action you get from these muscles. The supraspinatus is on the right. It's going to be pulling the humerus up in here. And when it relaxes, it allows it to drop down. That's the supraspinatus on the right. On the left-hand side, you've got the subscapularis pulling the shoulder, pulling the humerus towards the front of the body. You have the infraspinatus and the teres minor pulling the humerus towards the posterior side of the body. But these muscles don't work in a vacuum. They don't work independently. I mean, they could, but they work together. So that, yeah.
What happens whenever you dislocate?
Oh, good question. What happens when you dislocate the shoulder? A lot of screaming and pain.
I know my mom goes.
Yeah. Now, what happens is that usually the tendons may become stretched a little bit, and you tend to, if you're lucky, you pop it back in place. Now, because if you haven't torn the tendons that are attaching the rotator cuff muscles to the head of the humerus, okay, it's sort of dangling down there a little bit. You have to pop it back into position. Did you stretch the tendons too much? Are they torn? Maybe, maybe not. Over time, they may become weaker and weaker and are more likely to tear. But usually what happens is that since it's such a flat socket, if it is a socket, such a flat structure here, it's easy, given the right type of trauma, to force the head of the humerus out of position. And it can drop down, it can go to the side. Usually you're not going to have a lot of tearing or any kind of physical trauma to the muscles. And in many cases, just can pop it back in place, without having to do anything else. But if I've always heard that once it happens the first time, then it's prone to happen again. And the more it dislocates, the more likely it is to cause some sort of damage that you're going to have to eventually get it surgically repaired.
My mom's had like 3 or 4 of those surgeries. Her last one, they took 4 inches or took bone from her hip and put up there. But she has so many scars. They said the next one's just going to be a shoulder replacement.
It dislocates all the time, but it doesn't.
Oh, when it dislocates, it just pops out. You don't have to demonstrate. So, Thank you. So, yeah, and I've also heard of individuals that it's a routine thing that you can do. You know, some people can dislocate their shoulder when they want to, for whatever reason. It just depends on how flexible the joints are to begin with, too. I've never, my son, one of our sons is double jointed, you know, as they say. And we know there's no such thing. I've never asked him if he could dislocate his shoulder or not.
I can dislocate this one, because I've heard it push going, like trying to get it started.
Uh-huh.
And it's just been able, like, it just does all the time. I
Okay.
use it, like, where I go like here, it locks up.
Hmm.
And that's like,
Okay. So, well, you know, like I said, a lot of times you're lucky that there is no lasting injury. That part's good. So maybe arthritis later in life, but you know, something to look forward to. Yeah. You know, well, we all get arthritis. You know, we all get it. 95% of the population gets arthritis. So don't, you know.
I already have it in my feet. It's not that
5% are in denial.
Yeah.
bad. Yeah, the rest are just in denial.
Yeah. So, okay. So the rotator cuff, you know, you know, all sorts of things can happen at the shoulder. The shoulder is not the most complicated joint that the knee is, believe it or not, but all sorts of things can happen at the shoulder. It can do strange things to us or for us. So anyway, these muscles work together to give us an extreme range of motion here. Here we're seeing the supraspinatus and the teres minor. While, you know, the supraspinatus is causing the arm to adduct, to move away, to abduct, to move away. It's not doing it by itself. You're going to have the effect of the teres minor and the infraspinatus with it. The same with the teres minor here, allowing the arm to rotate. All four of these muscles work together to give us this range of motion, because as we move our arm around, other muscles take the lead in what we're doing. So, and again, you can see how the infraspinatus can pull the arm backwards, whereas the subscapularis pulls it forward, and they're working antagonistically. But all four of these, again, are attached to the head of the humerus. So if you want to do something with your arm, you're going to use all four of these muscles. And this is probably why we get so much damage on it over a lifetime. Sports injuries, very common, overuse at the shoulder, wear and tear, trauma later in life. I have a friend that tore the tendon in his rotator cuff falling off of a treadmill. You know, and it's you know, if you're using a treadmill and if you're not prepared when it starts, it can surprise you. You know, so and that's what happened to him. And people fall down. You know, plus, you know, elderly people have a lot of wear and tear. And so they have to have rotator cuff surgery too. Now, the rotator cuff repairs usually involve fixing the torn tendons. The tendons, which are made of collagen, are very strong, but they do wear out. And the surgery to fix this usually involves having some sort of synthetic plastic type insert that you weave the muscle through and weave the tendon through, and it sort of joins the two pieces together. And, you know, it works. But the recovery time is probably 4 months, 4 to 6 months for the recovery. Okay. Now, looking at the leg. Okay, first thing we see here is the tibialis anterior. That's easy to find. It's on the lateral side of the anterior crest of the tibia, you know, the shin bone, the one that we use to find things in the house at night when it's dark. We walk around and say, oh, that table wasn't there yesterday, you know, things like that. The tibialis anterior sits next to the anterior crest. The tibialis anterior allows us to raise our toes when we walk. Now, we're not aware of that. Most of us don't think about the position of our feet when we walk. Because if you watch yourself walk, you're going to fall down. You know, trust me, I've tried it, and you don't ever try it on the stairs. I'll just say that. So, the tibialis anterior causes you to raise your toes when you walk, and that causes your heel to go down. And its antagonist is the gastrocnemius, your calf muscle, which raises your heel when you walk and causes your toes to go down. So we tend to walk heel to toe, heel to toe. And so the tibialis anterior is this raising the toes, putting the heel down when we take a step. Adjacent to it, just slightly behind it, is the extensor digitorum longus. So digitorum longus causes our toes to splay out when our toes go down. And that's for stability. We don't pay attention to it when we have shoes on and everything, but when we step down, our toes will still stretch out. So we have a more stable position for when we're standing. And the extensor digitorum longus is doing that. Notice the tendons that are stretching out from the end of that down across each of the toes. Now the peroneus longus and the peroneus brevis, if you have a longus, you're going to have something that corresponds to longus. Like shortest isn't a word that we would use, but we would use brevis for brief, and that's the peroneus brevis right there. They control, again, they work with the positioning of the toes when we step. Here we have our gastrocnemius. The gastrocnemius originates on the medial and lateral condyles of the femur. It inserts on the calcaneus by way of the Achilles tendon. And this is what we use to raise our heel when we step. And when we raise our heel, our toes go down. So it is the antagonist to the tibialis anterior in here. Okay. Directly in, there's the Achilles tendon right there. And then sort of tucked away underneath the gastrocnemius is the soleus muscle. We can't even see it on the models other than just a little ridge on the plastic model now. Okay, there's the gluteus maximus. Nobody ever gets that wrong on the muscle test. It has it's a large muscle involved with moving our thigh. It actually does have a purpose. And then in the front side, and this is mostly on the lateral side of the leg, is the tensor fasciae latae. Now, important thing to remember, when you're looking at a model or looking at a picture of a model, the little toe is always on the lateral side. Always remember little lateral. Okay, so the little toe is always on the lateral side. That means that just like with the skeleton and the head of the femur and the head of the humerus were on the medial side of the body, and the epicondyles, if it's lined up with the head of the femur, if it's lined up with the head of the humerus, it's also on the medial side. Little toe on the skeleton is on the lateral side. The big toe is on the medial side. Same thing applies when we have the muscles in place. Little toe is on the lateral side. Big toe is on the medial side. Okay. So there is our tibialis anterior right there. So on the front of the tibia, it allows the dorsiflexion of the foot. In other words, the toes come up. That's dorsiflexion. The toes come up, the toe is inverted. And so we see exactly where it's located. It shows up on the lateral side of the tibia, on the side with the fibula, on the lower leg. See where it's located there, right next to the anterior crest. And again, its role is to raise the toes. And when the toes go up, the heel has to go down. So The counterpart, and we'll talk about this in a few minutes, is plantar flexion, where the heel comes up. That's what the gastrocnemius does. Now, dorsiflexes and inverts the foot. Now, the gluteus maximus rotates the thigh, but just be able to identify this. You'll notice that the gluteus maximus is right there below the iliac crest. If I had my pen, I could mark it, but the iliac crest is this area right here. You can feel your iliac crest on your side. You can find the iliac crest very easily, the top of the ilium there. The gluteus maximus starts just behind the edge of that. So, in fact, we use the iliac crest as a landmark to find the gluteus medius. We don't give injections in the gluteus maximus because the sciatic nerve runs right underneath the gluteus maximus. And at the point there where it runs through, it's about as big as your finger. So it's sort of like screaming, hit me, hit me. With, you don't want to stick a syringe, a needle into the sciatic nerve, because that would be a whole new experience in pain. So we give injections. If you ever get an injection in your hip, it's usually in the side. It's in what's known as the gluteus medius. We find the gluteus medius by finding the iliac crest and then coming back about 2 fingers width, and there's the medius. Because again, the same rules apply. We don't address it here. If you have a maximus, you're going to have a minimus. You also have a medius in here. So, depending on what kind of healthcare area you're looking at, you'll probably learn a lot more about how to find that location. But if you ever, think about it, the next time you're at getting an injection of something and it's in the hip, it's not going to be straight into your butt. It's going to be off to the side in the medius. Okay. Now, the quadriceps muscles. They are the 4 large muscles in the front of the thigh. 3 of them have the same name. They're the vastus lateralis on the lateral side, the vastus intermedius in the middle, and the vastus medialis on the medial side. And then covering the intermedius is the rectus femoris. So these 4 quadricep muscles, or the quads, are the antagonists to the 3 muscles behind the thigh called the hamstrings. Now, the quads allow you to flex the leg. So we can flex our leg here. So the quads allow us to bend our leg at the knee. We're flexing it. We're bringing the angle. We're decreasing the angle between the tibia and the femur. So we're flexing the leg there. So we're flexing the thigh, but we also use it to extend the lower leg. So we flex the thigh. So this is what the quads do for us. So it's like you're bringing your leg up like this. This is, you're using your quads to do this. You can feel your quads tightening just by doing this kind of action here. Now, the counterpart to this are the hamstrings. There are 3 of them. On the posterior surface of the thigh, we have the biceps femoris, the semitendinosus, and the semimembranosus. Now, the biceps femoris is on the lateral side of the thigh. The semitendinosus and the semimembranosus are on the medial side. Now, how do I remember that? Well, semimembranosus, there's it's semi and then membranosus, there's an M there. So I use that as my memory aid to say it's on the medial side. Which one's on top? The tendinosus, T for top, is on top of the membranosus. So you have these 2 muscles sandwiched on top of each other on the medial side. The semitendinosus is on top, the membranosus is underneath. they are the antagonist to the quads. So if the quads, let me go back and show you that again. If the quads are there to flex the thigh, the hamstrings, which we can see here, biceps femoris, semitendinosus on top, semimembranosus underneath. You know, the model is not great because it doesn't separate out, but the membranosus is underneath it. That tells you also that's the medial side. It's on the medial side of the leg, or on the thigh now. So what do they do? If the quads flex the thigh, the hamstrings extend the thigh. So where your quads would allow you to do this, bend your leg here at the knee like this, what the hamstrings do is allow you to kick out. So, you know, if I'm doing this, I can feel it contract here. I flex the leg. If I want to kick my leg, if I want to kick my leg out, I can feel it underneath here. So the extending the thigh is the opposite of flexing the thigh. These are antagonistic muscles. Let me show you this. Okay. There we are on the left, flexing the leg. We are flexing our leg with the hamstring, but the quads are allowing us to extend the leg. So when we take a look at reflexes in the last unit in the lab, and I'll turn everybody loose that shows up with rubber mallets to hit each other with. They're only rubber mallets, they won't hurt. We'll do the patellar reflex. We'll tap the patellar tendon and watch your leg kick out, maybe, if it works. What that's doing is stimulating the patellar reflex causes your leg to kick out. We're stimulating the quads. We're mimicking a nerve impulse in the leg, and we're testing to see if the nerves that are controlling the lower leg are working. So anyway, here's the difference. Whatever the quads do, the hamstrings are the opposite. Whatever the hamstrings do, the quads are the opposite. So if the hamstring flexes, then the quads extend. If the quads flex, then the hamstring extends. They are antagonistic muscles. So, okay. Now on the inside of the thigh, we have a series of muscles here, mostly for stabilizing the position of the thigh. We have a most unique looking muscle here called the sartorius. It's shaped like a big strap, and that's sort of how it functions. It comes down across the inside of the thigh and anchors down near the inside of, near the knee. This is what allows us to sit on the floor cross-legged. It allows us to stretch our leg around, to twist our body around so that we can sit comfortably, more or less, on the floor with our legs crossed. That's the sartorius. Now, on the medial side of the thigh, there is this muscle called the gracilis. The gracilis runs all the way from the inguinal region down to the knee. Again, it allows us to, as I say, rotate the thigh, but also stabilize the thigh. So it's a very, very prominent muscle that runs right along the inside on the medial surface of the thigh. We have two other muscles here called the adductor longus and the adductor magnus. Adductor longus and the adductor magnus. The adductor longus runs between the gracilis and the sartorius. It runs under the sartorius, and the adductor magnus runs under the gracilis and also runs under the sartorius. You can see the adductor magnus is over here, running down this way, and the adductor longus is here. All of these allow us to have motion of the thigh, to the position, whatever position we're to turn, to rotate, to sit down, whatever. So there's the sartorius. When we cross our legs and sit on the floor, we're using this, allowing us to bend our thigh around. now. And so of all those, the gracilis and the sartorius are probably the ones to remember. Okay. Now let's take a look at the lower leg. This is the gastrocnemius muscle. It has two origins. It has a medial head and a lateral head. The medial head originates on the medial condyle of the femur, and the lateral head originates on the lateral condyle of the femur. Their insertion is on the calcaneus bone in the foot by way of the Achilles tendon. So here is our lateral head. There's our medial head. There's our Achilles tendon right there. And this is the calcaneus bone here. Now, the gastrocnemius allows us to have what's known as plantar flexion, where we raise our heel. We raise our heel and our toes go down. So when we walk, we start out by our heel goes down. We have the Tibialis Anterior to thank for that. The heel goes down, the toes come up. Then we raise our foot. Thanks to the gastrocnemius, our toes go down. We take the next step. Our heels go down. Our heel comes up. Our toes are down. Our toes go up. Our heel goes down. That's how we don't think about it. If we thought about it, we'd be falling down all the time. But this is what the gastrocnemius does. It's called plantar flexion. Okay. Medial head, lateral head. Got to give credit to the soleus in there. And there's the Achilles tendon. And again, now we can see the lateral condyle and the medial condyle, the lateral head and the medial head, and we can see where it inserts itself on the calcaneus muscle, calcaneus bone right here, causing the heel to go up. And notice how when the heel goes up, the toes go down. So that is what's known as plantar flexion, as opposed to dorsiflexion when the toes go up. Okay, and again, dorsiflexion, toes up, thanks to the tibialis anterior, and plantar flexion, thanks to the gastrocnemius. Okay. Now, moving on to the muscles of the torso. The muscle that nobody ever gets wrong on a test, and I promise it'll always be on there, is the frontalis muscle. It's a very thin muscle. You can feel your bone. You can feel the frontal bone just rubbing your forehead. So that tells you that the thickness of that muscle is very, very thin. If you can feel your bone right through here. The frontalis muscle is pretty much for showing expression. It's an expressive muscle. It doesn't do a whole lot for us as far as movement. It shows facial expression. As do these two. The orbicularis oculi, the round muscle around the eyeball, has nothing to do with movement of the eye. The muscles that control eye movement are embedded in the socket, but this is around the eye. And the orbicularis oris, around the mouth. It has nothing to do with eating, but it has everything to do with showing expression. Both of these allow us to show expression. And of course, there's the frontalis on the model, and the orbicularis oculi, oculi for ocular, and the orbicularis oris. These are circular, these are flat circular muscles. And again, all they do is allow us to show expression. Another set of muscles here that are expressive are the zygomaticus muscles. There's a band of several muscles that come down off of the zygomatic bone, but they seem to connect right around the area of the orbicularis oris. Close up again. Now here is a muscle that does something for us. The temporalis muscle is one of our chewing muscles. this muscle on the side of our head. Its origin is on the temporal bone. It inserts itself on the mandible, and it allows us to chew, because chewing involves bringing the mandible up against the maxilla. It's the only way we chew. The maxilla doesn't move. We grind our food against the maxilla. So the temporalis muscle is actually a working muscle. It involves the process of chewing. There's the zygomaticus muscles there, expressive, for showing expression. There's the other chewing muscle, is the masseter. The masseter's origin is on the zygomatic bone, and it also inserts on the mandible and works with the temporalis to pull the mandible up against the maxilla. So we chew when we eat. So this is another working muscle. It's right in front of a big salivary gland, that little pink thing, that structure in front of below the ear. The tan structure below the ear is the parotid gland. It's a very large salivary gland, and the masseter muscle is right in front of that. And again, there's the masseter right there. There's the parotid gland up here. And there's my favorite, the sternocleidomastoid muscle. The sternocleidomastoid attaches, its origin is on the sternum and the clavicle. It inserts on the mastoid process. It allows us to turn our head to the left or to the right, or to nod it up and down like this. So set of two large muscles here. You're either going to turn to the left or turn to the right. If they both contract at the same time, they will pull you back and forth like this. So rotating the head, notice how the muscle that contracts, in this case, if we're looking to the left, it's the left sternocleidomastoid that's contracting, pulling the head over in that direction. So you can look to the left or to the right. So if you pull them together, if they contract together, the head will nod. And we fortunately can't do things like that. We can't rotate our head around. Owls can do that. If you've ever seen an owl turn its head most of the way around, we sort of can't do things like that. So, okay. Now, the chewing muscles, as I said earlier, the temporalis and the masseter, right there and there, both insert on the mandible. The temporalis muscle comes off of the temporal bone, inserts on the mandible. The masseter comes off the zygomatic bone here and inserts on the mandible. So there's the temporalis there, elevating the mandible. There's the masseter, elevating the mandible. And this is the result of that action. We see the chewing image on the right-hand side. You can see, soft tissue doesn't show up well. We see the tongue, but that's about all. But we can see the teeth, and we can see the jaw, and we can see how the maxilla doesn't move. Only the mandible moves. The mandible is brought up against the maxilla. And this is how we chew. Okay, moving down a little further now. This large muscle on our shoulder is called the trapezius. The trapezius allows us to elevate our head, like when we raise our head up to look around, for example, or to shrug our shoulders. There's a lot of things other than that, but those are, we all do that. We are using our trapezius. It sets above the deltoid. Remember, the deltoid covers the shoulder. The trapezius is above the deltoid. We also have the pectoralis major. If you have major, you're going to have a minor. Now, on the torso model, it pretty much only shows the pectoralis major, but there is a slight edge to it that I suspect is the minor, because the major and minor muscles here tend to run together. So I'll show you the minor, what I think is the minor in a little bit. Okay, there's the trapezius. it's a large muscle. It covers, it goes all the way to the base of the skull and down to about, looks like the end of the thoracic vertebrae here. We use that muscle, the trapezius, to raise our head up, for example. So we shrug our shoulders, we raise our shoulders up, we can tilt our head side to side. We can stand up and raise our head up to look around. Any kind of these actions like that are going to be what the trapezius is involved with. Okay. Pectoralis major, large muscle in the chest. You know, when we exercise those muscles, they get larger. You know, we don't lay down new cells, we just allow them to get bigger. If we're climbing, if we are rowing, if we're throwing things, if we're doing push-ups, we're going to use the pectoralis major. Now the minor is usually underneath it, usually running in the opposite direction. You can see how the muscle tends to line up with the sternum and the humerus because it inserts itself on the humerus. The grain of the muscle tends to run in a horizontal pattern that way. The pectoralis minor, if it's underneath this, as I suspect it is, if what I think they indicate for the minor is on the model, it's going to run in the opposite direction. Most muscles, when you have a major and a minor, or an external or an internal, will crosshatch themselves for greater strength. They'll run in opposite directions. And it actually sits on top of the ribs. And when we get into AP2, we'll talk about breast cancer and breast removal and mastectomies. And in many cases, the extreme removal of the breast also involves removal of the pectoralis major down to the level of the ribs to make sure that all the cancer is taken. So it sets above the ribs. Okay, so now we're looking at a large muscle of the lower back. This is the latissimus dorsi. The latissimus dorsi is your throwing muscle. It is your chopping muscle. It's your driving a nail muscle. So hammering or chopping or throwing things, particularly if you were playing softball. Underhand throwing, you know, some people bowl, some people throw things underhanded. They are using their latissimus dorsi when they do that. If you are nailing down, if you're working on a floor or a deck and you're doing a lot of nailing, you're using latissimus dorsi. It gives you the power stroke in that particular type of action. So pounding a nail with a hammer is latissimus dorsi. It's a large muscle. It extends all the way down to the sacrum, and you'll notice that it inserts itself on the humerus. Consider the size of that muscle and the power that it can give to the humerus to do things with. So a power stroke for hammering or chopping. You know, if you've ever watched softball, highly competitive softball, when they're throwing underhanded at 100 miles an hour, you know, which is as fast as a ball comes in from overhand. You know, consider the power that you're using from the latissimus dorsi to do something like that. So it's a very powerful muscle. And again, you can see, there we go. So like, for example, a person that would be throwing underhand or bowling, for example, or any kind of action like this, where you want to apply a great deal of power, you're drawing on all that power from that muscle, and it's being delivered to the humerus. The rectus abdominis here, this is the six-pack muscles. It starts at the xiphoid process, it terminates at the pubic bone. It when we contract this muscle, our abdomen flexes, our abdomen shrinks in. When you go to pick up something very, very heavy, you often flex this muscle, because what's happening is you try to stabilize your abdomen, your abdominal cavity. So you go to pick up something very heavy and you're picking it up like that, and you're straining very hard, and your muscles are getting tight right in here so that you can apply energy to lifting it up. It's the same type of action, though, that someone does if they're constipated. Someone who is trying to empty their bowels. We all know old people. We all know how old people like to talk about their bowel movements, you know. Just get them started and they're going to be on that for an hour, you know. And I'm only slightly exaggerating too when I say that, you know. So, but what happens here? Why do we care about when they empty their bowels? Because when you compress, when you contract the rectus abdominis, you raise pressure inside the abdominal cavity. And within the abdominal cavity is a great big nerve called the vagus nerve that runs directly into the heart and controls the heart rate. If you stimulate that vagus nerve by compressing the abdominal cavity, it will cause your heart rate to slow down. And if you compress it enough, it will cause your heart rate to stop. Plus, when you're contracting the rectus abdominis, you're not breathing. Think about it. You go to pick up something very heavy and you're contracting that muscle and you're not breathing, because guess what has to happen when you breathe? Your diaphragm has to drop down into the abdominal cavity so you can take a breath. Well, it can't do that if the rectus abdominis is contracted. So you're not breathing and you're stimulating your vagus nerve. If you've ever picked up something really heavy and you've gotten a little lightheaded or a little dizzy while you're doing it, you know, or maybe you get almost like your field of vision shrank a little bit, it's because of compressing the rectus abdominis. Now, how does this have to do with old people and constipation? Well, people that have had heart attacks are often given pain medications that cause constipation. Numerous pain medications will cause constipation. Even Advil will cause constipation. It reduces the motility of the constipation is caused by a lack of water in the colon, large intestine. Advil reduces that motility. Morphine sulfate, morphine painkillers does the same thing. So now you got this heart patient who has survived a heart attack. They're taking pain medication and they can't empty their bowels. And so what do? The first chance they get, they run into the bathroom and they strain to empty their bowels and they drop dead because their heart's already weakened from the injury, from the heart attack. And the vagus nerve causes the heart rate to slow down till it stops. So this is why when you're dealing with heart patients, and you'll get a lot more about this later on, when you're dealing with heart patients, you can't let them go to the bathroom by themselves because they might, you know, lots of people die straining. In fact, they call it straining at the stool, you know, because they strain and strain and strain, and they are stimulating that nerve in there. So, and but the rectus abdominis is going to stabilize our abdomen. It also causes us to hold our breath because of that too. So, okay, now the external obliques are right beside the rectus abdominis, and they're going to compress the abdomen. They're off to the side here. If you want to know where your external obliques are, stick your hands in your pocket and point the fingers towards the midline of your body, and that's where the external obliques are. They compress the abdomen. So you're flexing the abdomen, but now you can compress it too. And again, we do both of these to stabilize the abdomen when we're lifting something heavy, or we're moving something, or we're straining at something, or when we cough really hard or sneeze really hard, we can stimulate both those muscles. Okay, now, okay, here we have the serratus anterior. The serratus anterior is another muscle that attaches itself to the humerus. This is often referred to as the boxer muscle, because this is the muscle that allows you to put a lot of force in your humerus, you know, and a boxer will use their serratus anterior for quick punches, for example. And a good defensive mechanism against that is to punch along the side to make the serratus anterior sore so they don't have the power to punch back. So there's the external intercostals. There's two sets of muscles in our ribs that allow our ribs to inflate, to rise when we breathe, and to deflate when we breathe out. If you've ever eaten ribs, you've eaten intercostal muscles. So there's the rectus abdominis on our model, the six-pack again. There's the external obliques right there. Now, if we look at the other underside of the torso, we can see the internal intercostals, because I said if we have an external, we got to have an internal. The external intercostal muscles in our ribs, the grain of the muscle runs towards the sternum. When they contract, our ribs rise. When our ribs rise up, the thoracic cavity enlarges. At the same time, the diaphragm drops down. So we practically double the size of our chest cavity. Our lungs are stuck to the inside of the chest wall. So wherever the chest wall goes, lungs go with it. And when that happens, air rushes in. Since we can't keep it there very long, we have to blow it out. And so the internal intercostals contract and cause the ribs to drop down and air is blown out. And those are the internal intercostals there. The grain of that muscle runs away from the sternum. There's the internal obliques. You can't tell much about this at all. They run in opposite direction of the externals. Again, when the muscles crosshatch like that, it reinforces the strength. Transverse abdominis runs all the way across the front of the abdominal wall. And there's the diaphragm. Now, the diaphragm is not just a skinny little line there. However, if you were to see a picture like that with an arrow pointed to that area there, it would be diaphragm. If it's down below, it's the transverse abdominis. The diaphragm actually is shaped like a parachute. And the peak of the diaphragm is right about the xiphoid process. There's our intercostal muscles. The sternum is over here. You see how the grain runs towards the sternum. The internals, the grain is running away from the sternum. The external intercostals elevate the ribs. When they contract, the ribs rise up, and the intercostals depress the ribs. This is what the diaphragm looks like. The peak in the front of the diaphragm is right there at the xiphoid process. You can see the pointy end of the xiphoid process there at the end of the sternum, and it covers the top portion of the abdominal cavity. Now, when the ribs rise, when the intercostal muscles contract and the ribs rise up, at the same time, the diaphragm drops down. And when it drops down, when the diaphragm drops down and the ribs rise, the chest expands and takes the lungs with it. The air pressure inside the lungs drops and air gets sucked in like this. So we can see the diaphragm relaxing, going up. Now when the diaphragm contracts, it goes down and the ribs are going to rise up at the same time. And there goes the diaphragm down, it's contracting, and now we'll see there we go. When the ribs rise, the diaphragm goes down. And when the ribs relax, the diaphragm goes up, back and forth like that. And so this is the whole process of breathing. To get air to come into our lungs, we simply increase the size of the lungs, which lowers the air pressure, causing air to come in. So, and that is the end of that. Any questions on any of this? Okay, then I will get rid of this or close this off, and I'll see you all on Thursday.